Good morning, all. Welcome back to Open Med School. Today, we are going to discuss how to take the history in a patient with the gastrointestinal problems. I request you to watch the video lectures on history taking part 1 and part 2 of Open Med School before going into the details of gastrointestinal examination. As in any other system, start with the presenting complaint. Presenting complaint is the problem for which patient has approached you. So use an open question like, what has brought you to see me today, or what are your issues? Listen to the patient. Facilitate the patient by repeating the end of what they have said, or some gestures, or by telling what else, something like that. So in the initial part, try not to interfere by asking questions. So the key gastrointestinal symptoms or the presenting complaints, you can think in two lines. One as upper gastrointestinal symptoms, second lower gastrointestinal symptoms, and also there are systemic symptoms. Another way is to think in terms of organ systems. For example, starting with the mouth and oral cavity, esophagus, stomach, hepatobiliary system, pancreas, small intestine, large intestine, including rectum, then the renal system. So two ways we can think about the gastrointestinal system. So the upper symptoms are aphthous ulcerations, dysphagia, and painful swallowing, otherwise called odynophagia, jaundice, abdominal pain, vomiting including hematemesis, gastroesophageal reflux symptoms. In the lower GI, the predominant is abdominal pain, abdominal distension, change in bowel habits, constipation, diarrhea, steatorrhea, melena, and hematochezia. So these are the major gastrointestinal symptoms. In addition, there is always systemic symptoms you should ask about. Anorexia, weight loss is a common in malabsorption, malignancy, and HIV infection. Ask about nausea, fatigue. Other systemic symptoms can occur. One is fever as an intra-abdominal infection, like a liver abscess, acute gastroenteritis. This can also be a presenting symptom of inflammatory bowel disease. Pruritus can occur in cholestasis, that is in obstructive jaundice. Confusion may be a feature of hepatic encephalopathy. So think about upper GI symptoms, lower GI symptoms, and also systemic symptoms when you take the history of a patient with the gastrointestinal problem. Once you have identified the presenting complaint, ask the patient what else, anything else you have to say. So fix the agenda. What is the presenting complaint, or what are the presenting complaints, and discuss with the patient about which you are going to take the history of presenting complaint. This can be done in two ways. One by the mnemonic OPQRSTA, or you can use the term Socrates. O stands for onset and P stands for the position. Q stands for the quality or the character. R stands for aggravating, relieving factors, and also radiation. S stands for the severity. T stands for the temporal progression, how the disease occurred, and A stands for the associated symptoms. This is the 7-dimensional analysis of any symptom. Whatever it be, any symptom, you should think in these lines, either use Socrates or OPQRSTA. Dysphagia is an important symptom. You should definitely ask about whether it is more for solids or liquids. Dysphagia for solids is suggestive of a mechanical obstruction. Dysphagia more for liquids suggests neurogenic cause. For example, in myasthenia, tendinous palsy, it will be more difficulty for swallowing liquids. There can be nasal regurgitation, tracheal aspiration, and patient may cough. So that is the importance of asking in the history of dysphagia. Second, you should ask whether the dysphagia is painful or painless. Painful dysphagia is otherwise called odynophagia, can occur in esophagitis, candidiasis, etc. Again, depending upon the site, you should identify whether it's a oropharyngeal stage or in the where is the food sticking, that is in the upper part, mid part or lower part, so that this will give an idea regarding where is the obstruction. Abdominal pain is one of the very important presenting symptoms of GIT disease. The location is one of the most important thing that narrows the differential diagnosis. We can go by a quadrant approach, that is the right and left upper quadrant, right and left lower quadrant. When you get a right upper quadrant pain, first you think about cholecystitis, cholangitis or any hepatic problem. The epigastrium or this region, that is the right and left upper quadrant, this can be pancreatitis also. Pain from the umbilicus radiating to the lower quadrant on the right side, always think about appendicitis. On the left side, think about diverticulitis. In the lower part, this region, always think about bladder and ovarian lesions. So, summarizing, right iliac fossa pain, here think about appendicitis, ectopy pregnancy in regional ileitis or Crohn's disease, inflammatory bowel disease also can produce pain here. The left iliac fossa or the left lower quadrant, think about diverticulitis, ectopy pregnancy. In the epigastric region, think about esophagitis, gastritis and pancreatitis. Right upper quadrant already mentioned, related to the liver, cholecystitis, hepatitis, liver abscess. Flank pain is important because from the loin to groin, the pain is characteristic of renal. The suprapubic region, again as mentioned, bladder symptoms. Another way of thinking is looking into the 9 areas. 2 vertical lines. There is one line from the middle of midclavicular line to the mid-inguinal point. So 2 lines like this and 2 transverse lines. One is a transpyloric line that is at the level of L1 vertebrae, and second is the intertubercular line, that is 5 cm from above the anterior superior iliac spine. You divide into 9 areas, not quadrants. So here the right hypochondrium, as mentioned, it is related to the liver, hepatitis, abscess, cholecystitis, cholangitis or gallstones. On left side, pancreatitis, splenic infarct, splenic rupture or anything related to the spleen. In the epigastrium, it is related to the gastritis, reflux disease, peptic ulcer, perforation, gastroparesis. The lumbar region, it is renal stones, and sometimes pyelonephritis or colitis. Same side, same way on the left side. In the umbilical region, this small bowel obstruction. Anything which is arising from midgut, you get this region pain. Can occur in gastroenteritis, mesenteric ischemia, ruptured aortic aneurysm also. And right iliac fossa, think about appendicitis, colitis, ovarian torsion, ectopics, ovarian cyst. Same way on the left side. Instead of appendicitis, think about diverticulitis. And in the hypochondrium, you can get cystitis, pelvic inflammatory disease, again ectopy pregnancy. Okay, this is how by area wise the location of the pain. The major symptoms we have mentioned, 1 or 2 symptoms we will discuss in little detail. For example, gastroesophageal reflux disease, very common. The site of pain, usually it is in the epigastrium. The onset aggravating factors are bending over and lying down. So the patient may say, I got epigastric pain which aggravates on bending over or lying down. The character is usually burning, or this pain may be going up to the throat with acid sensation in the or a sore sensation in the mouth. The pain may be radiating, as I have mentioned. Relieving factors by taking antacid. Exacerbating factors already mentioned, bending over and lying down. The severity depending upon the severity you can tell. So this is how you apply the 7-dimensional analysis of symptoms for abdominal pain of gastroesophageal reflux disease. In peptic ulcer, again the pain, the site will be epigastric. It may be aggravated or worsened by meals in gastric ulcer, improved in duodenal ulcer. The character of the pain is burning or dull pain. It may radiate to the back and relieved by antacids. But timing and progression you have to tell depending upon the patient's symptoms. Exaggerated by often by spicy food and NSAIDs. Severity again you have to assess depending upon the grade of symptoms or their activities or daily life is interfered with. You can think about so any of the symptom can be analyzed on the sign 7-dimensional. When coming to upper GI bleed after this sort of discussion, you should also think about what were the risk factors, why it occurred, whether it is due to NSAID use, alcohol, smoking, H. pylori infection, stress, and also ask about whether there is any change in the stool, because melena is a dark, tarry stool, foul smelling due to the altered blood that is passed through per rectum. And you should ask about the vomitus, which may be coffee ground, or whether it is red blood, as in fresh hematemesis. When there is too much of blood, there is no time for the blood to react with the hydrochloric acid to form acid hematine. When we say upper GI bleed, the cutoff point is the ligament of Treace. Then coming to pancreatitis, one of the causes, the site of pain is usually epigastric. Pain can be aggravated with meals, dull and steady. This may be referred to the back. The alleviating factors, by sitting and leaning forward, the pain may get relieved, and the meals and alcohol may worsen the pain. So this is again the 7-dimensional analysis of a pancreatic pain. The biliary pain is characteristically the pain, as already mentioned. It can be in the epigastrium, as in a common bile duct obstruction, or in the hypochondrium and the cystic duct is blocked. The pain may be acute episodes or can be recurrent pain, usually very severe pain. Even though it is called colicky, sometimes the pain can be constant pain. It may last for hours. And the characteristic radiation can occur to the shoulder region. This should be kept in mind. That is epigastric pain with radiation to shoulder. Think about biliary colic. Then we are all familiar with the renal colic. The pain is said to be from loin to groin. That is, it may be in the loin region. It may refer to the groin. It may go to the inguinal region or even to the external genitalia. The pain is usually severe, can be constant or colicky pain. Rolling around often improves the pain. So the patient will be usually restless and they will be moving around. So that is a characteristic pain of renal colic. This may be associated with hematuria or difficulty in passing urine also. So these are the additional points to be asked about. Then bowel obstruction, it can be either large intestine or small intestine. The small intestine is arising from the midgut, so usually the pain is around the umbilicus. And the large bowel also can produce pain, and the pain may vary, the site may be varying, and the pain is typically colicky pain. That is, the pain waxes, goes to a maximum, then it goes back. So that is what is called as this waxing and waning pain, which all of you are familiar, and it's characteristic abdominal colic. And pain rolling around often improves the pain. Or this may be relieved, there may be associated vomiting, or there can be constipation or even obstipation, that is non-passage of even gas. So these are the symptoms of a bowel obstruction. And depending upon the type of obstruction, you may get the visible peristalsis, that is the movement of the intestine, can also be visible in this sort of patient, or they may say that there is a rolling off, or the prominence of abdomen or prominence of the intestine may be mentioned by the patient also. Jaundice is a very important symptom. We will discuss it in detail. Minimum thing you should remember, a dark urine, pale stool should be asked in any patient with jaundice which favors a biliary obstructions. That is, in obstructive jaundice, you get a clay-colored stool. That is the term you should use, a clay-colored stool and a dark urine. That is characteristic of obstructive jaundice. And different things in addition to 7-dimensional analysis, you have to ask about the duration of jaundice. any previous attacks of jaundice were there, any pain that is suggestive of a hepatitis or cholecystitis, chills and fever and systemic symptoms that favors a cholecystitis, itching that is a pruritus favors obstructive jaundice. A drug history is very important. Prescribed, illegal or herbal medicines. Past history of biliary surgery, anorexia and weight loss suggests a malignancy. As already mentioned, color of urine and stool, contact with jaundice patients or anybody else in the family is having jaundice, history of injections, blood transfusion, tattooing, and what is occupation and any occupation hazards are there. So jaundice is a important topic and we'll discuss it in detail at some time. Divided into pre-hepatic, hepatic and post-hepatic, and what are the questions to be asked we can discuss in a later session. Another important symptom is diarrhea. Again, you go by the 7-dimension analysis. In addition, you may ask about the number of how was the onset, how many times they are passing, what is the volume, whether there is any vomiting. Presence of blood and mucus is very important because blood and mucus means it's dysentery and indicates usually a large bowel. The presence of fever, weight loss and abdominal pain is important. What is the effect of food on whether the taking food increases? So the effect of food should also be asked for. Then symptoms of dehydration should be asked, and the medications, because many times antibiotics can produce antibiotic-induced diarrhea, or patient may be taking some other over-the-counter medicines that may also produce change in the bowel habits like diarrhea. So that is the, and we divide the diarrhea traditionally into small intestinal diarrhea, large intestinal diarrhea, and the analysis will be different, and we can again this can be taken as a separate session. And in diarrhea, again always ask whether the diarrhea has made you awake from sleep and whether patient had a nocturnal diarrhea. It's especially important as in case of diabetes. The diabetic diarrhea due to autonomic neuropathy is more common at night. The pale and greasy smelling stool and difficult to flush away is characteristic of diarrhoea when there is malabsorption syndrome. Whether specifically ask about leakage of stool, because many patients may not give the history unless you specifically ask for any history of recent travel. And the history of inflammatory bowel disease, prior GIT surgery should also be asked for. Family history of celiac disease or again inflammatory bowel disease, and ask about history of any arthritis associated. Review of systems is very important. So by this review of systems, what we mean is history related to other system involvement. It is not examination, it is again history taking. We have already described the systemic symptoms like fever, weight loss, change in weight is very important, and fatigue should be asked in all patients. Ask about major cardiovascular symptoms like chest pain, breathlessness, palpitation, edema and syncope. In respiratory system, ask about dyspnea, cough expectoration, wheezes and hemoptysis or chest pain. The genitourinary system should be interrogated. Ask about oliguria, polyuria, dysuria, urinary frequency. Neurological symptoms like visual changes, motor or sensory disturbance, headache, confusion. So in fact, you should review the major symptoms related to other systems so that you will not be missing anything. In between, you summarize. Okay, we have talked about your symptoms and your concerns. Anything else you would like to discuss? Because many times patient may forget things and only finally after examination they may say. So in order to avoid this, you should again in between summarize the problem and also tell them I have covered this much and now going on to the next part of the history. That is, for example, here we will go to the past history. So past medical history is very important. You should ask not only medical but also surgical. So you should include the medical history, surgical history, and you can also take a obstetric history if it's a female patient. So ask whether you are having any medications, are you seeing any doctor regularly, and whether you have undergone any previous surgery. It's very important to ask this one also. And ask about investigations like endoscopy and colonoscopy and what were the results. In addition, you should ask about significant illnesses like diabetes, hypertension, coronary disease, etc. as in any case. A history of drug allergy and medications with side effects to gastrointestinal should also be inquired about, because opiates can produce constipation, penicillin can produce hepatitis, ondansetron can produce constipation. Tricyclic antidepressants can produce constipation. Metformin can produce constipation or diarrhea. So a detailed history, especially when there is a change in bowel habits. Now go to the family history. We are mainly concerned with the bowel cancer. Any family history of any bowel cancer. History suggests a hemochromatosis in any of the patients. History of inflammatory bowel disease. The familial polyposis which may predispose to colorectal cancer. They should be inquired. So whether any significant gastrointestinal diseases in the family. Do any of your parents or siblings have any liver or bowel problems? Because this will include the hepatitis, include Wilson's disease. All these are important. And when somebody has died in the family due to a GAT problem or due to any other problem, you should be very sensitive in asking and determine the age at which the patient had died and try to identify what is the cause of the death. You should be very sensitive in addressing this history. Now we go to the social history. So in the social history, we are mainly concerned with the social context of the patient and potential gastrointestinal risk factors. The most important risk factor you should think about is alcohol. So a detailed history of the alcohol consumption. In addition, smoking, sexual history, travel and diet is also important. We should ask about the social support and whether the house and other environment should also be asked for. There's something called the cage questions, especially when somebody is consuming alcohol. It's important to ask about the cage questions. C stands for the cutting down alcohol. Have you ever felt you should cut down your drinking? A stands for annoyed. How people annoyed you by criticizing your drinking. The G stands for guilty. Have you ever felt bad or guilty about your drinking? E stands for eye opener. Have you ever had a drink as a first thing in the morning to be steady and get rid of your hangover? So these are the cage questions. And a few words regarding alcohol. 1 unit of alcohol is approximately 8 grams of alcohol. It is equivalent to 1 glass of wine, 200 ml of beer and 1 peg. 1 peg is 30 ml. So 30 ml of alcohol contains approximately 8 grams of alcohol, the standard drink. You should again know how much alcohol do you have to take to develop liver cirrhosis. It varies between males and females. In males, 60 to 80 grams per day for 10 years. This is approximate. It may change with person to person. Females, 40 to 60 grams per day for 10 years is sufficient to. So when you take the alcohol history, you should try to identify whether the dose taken is sufficient to produce cirrhosis. Think about gastrointestinal risk factors. Identify the risk factors for gastrointestinal disease while taking the past history, family history, social history. In the social history, think about alcohol, smoking and recreational drugs and diet history. In the family history, specifically think about familial diseases like adenomatous polyposis and family history of malignancy. Now we should think about the ideas, concerns and expectations of the patient. You should ask whether the patient is having concern related to a malignancy. The consultation may be because one of their family member may be having a malignancy. So you have to address these things. Now it is time to close the interview. Summarize what you have learned from the patient, address their concerns and thank the patient and close the interview or continue with physical examination.
Eminent doctors talk on various topics. Stay tuned for